Hello! On this last voiceover lecture video for this module, we will look at the physiology of the respiratory system. So why don't we get started right away? What I want to next talk about with you is the fact that the process of respiration can be divided in 4 phases, and we will go through them by using the diagram that I drew and have put on the right side of the slide. So the first stage is called pulmonary ventilation, and if we think of the terms here, they are a very good description of what is happening. This stage refers to the movement of air in and out of the lungs, and there are 2 terms that I want us to be familiar with. Inhalation is sometimes also referred as inspiration, so this is the breathing in part. Gases move into the lungs. And exhalation then again refers to the expiration, so breathing out bit. Now gases exit the lungs. So really what is important here is that just getting the air into the lungs and all the way to the level of alveoli. And of course the reverse too, getting air from the alveoli all the way out from the body. Well, the next stage is described as external gas exchange. What happens here? Here we are looking at the process of exchanging gases between the alveoli, those microscopic sacs at the smallest level of the lung, and the capillaries, which were the rich blood supply that ran right against the thin, simple squamous cells of the alveoli. So what happens here is that we try to have as short distance as possible for the gases to travel, as the driving force for this exchange is actually the difference in the partial pressures concentrations. Remember how we talked in the past that materials travel passively from high concentration to the low concentration. And this is exactly the mechanism used here in the gas exchange. So as we see from the diagram, oxygen enters to the blood and carbon dioxide leaves the blood into the lungs and then entire body during the external gas exchange. Another interesting thing to note is that this is of course facilitated by our pulmonary circulation. Do you remember it from our earlier discussion of the cardiovascular system? Now, we are ready to look at the next phase, which is the gas transport in blood. So this is the oxygen and carbon dioxide being carried in the blood all around the body. So of course this part is facilitated by the systemic circulation. So you can see how all these systems tie in together. And the final step on my list is the gas exchange, but this time it is called internal gas exchange. This is because now we are exchanging gases as follows: oxygen from the capillaries in the body to the tissues, and carbon dioxide from the tissues to the blood in capillaries. And while I like this description of phases as it tells a nice story, the story of getting air from outside the body to getting it all the way to the tissues in the body, however, I often think that it leaves out one thing, or more like it does not highlight enough the fact that this works the other way around too. Gases are transported from the tissues to outside the body too. So just remember that. Maybe I should improve this listing somehow, like by removing the numbers or adding numbers as the gases travel the other way around too. Either way, those are our phases of respiration as your textbook describes them. Now I want to introduce another concept through clinical consideration. So before we jump into the clinical part, let's look at the picture here. So we see the pleural cavity with parietal pleura being on the outer one and visceral pleura being the inner layer. And between them, the space known as pleural cavity. An important thing to note here is that there is actually negative pressure in the pleural cavity. And this negative pressure keeps the lungs within this space of the thorax expanded. What can happen in some cases is that there is, for example, a puncture of the pleura. As a result, we lose this negative pressure. Notice the right lung, how it collapses as a result of that. And of course, we can try to treat this. But I think that the most important take-home message here is that this negative pressure and maintaining it is important for the lungs to be expanded. Now, I want to talk about what really happens in a muscle level in breathing in and breathing out. Let's have a look at that. So, when breathing in, so air is now flowing into the lungs, our external intercostal muscles, remember outermost muscles in between the ribs, contract, which causes the rib cage to be lifted up and out. However, although this expands the thorax some amount, the main respiratory muscle is the diaphragm. As it contracts, it loses its dome shape and goes downwards. So the contraction of both of these muscles increases the volume of the thorax. And again, larger volume means a lower pressure, so air flows in. So because these muscles are working, this is an active process. It takes effort to get air into our lungs. Now, let's look at breathing out. Unlike the previous one, this is passive process. So that means that it does not take effort for us to breathe out normally. What happens here is that the muscles that we saw earlier relax, and therefore the thoracic cavity's volume decreases. So this time, the pressure is higher inside the lungs than outside our body, so the air flows out. And then we can sometimes have a situation where we actively go further than the normal passive breathing out. This is called forced expiration. And here we recruit some muscles to assist us to really squeeze the chest cavity as small as possible. And these would be oblique and transverse abdominal muscles and internal intercostal muscles. When they contract, we really push the thorax volume as small as possible. So some effort is needed. And this next slide I wanted to add, as I just wanted to remind us all that it is not just the breathing that may move air in and out of the lungs. We have many non-respiratory movements with some good examples including coughing, sneezing, laughing, crying, hiccups, and even yawning. If you think about all these, they are typically something that are not under voluntary control, and they end up modifying our normal breathing pattern. There are a couple of terms or concepts, if you wish, that I also want to introduce, as we are not going to go through the next section in a great detail. I just want to give you a general idea of the important bits. So surfactant is this lipid protein complex. You can think of it as comparable to the detergent-like composition. So what it does is that it helps to reduce the surface tension of an alveolar fluid. In this way, it helps with the diffusion of the gases. And another thing that it does is they keep the alveoli from collapsing. We also have a concept of lung compliance. And while the definition that I have here is accurate, I find it a little challenging to get my head around. So I just tend to think about it as a measure of how much stretch a lung has. And higher compliance would mean that it is easier to expand the lungs. What I would like to do next is to talk a little about how we may assess ventilation. And what you see here is a very basic approach. It is a tool called spirometer. We can use this to measure the volume of air that you breathe out, or in more advanced approaches also the air breathed in. This in turn can give us very useful clinical information. For example, it can be used to identify conditions such as asthma, pulmonary fibrosis, cystic fibrosis, and COPD. Like I said, there are now much more advanced versions which are easier to operate and give us more information and are more reliable. But the basic concept is still the same. And some of the information that we can achieve with this is respiratory volumes and capacities. Let's have a look at those. So respiratory volumes, the volume of air breathed out, either normally or by putting in maximum effort, is quite useful for us. These volumes of air coming out or going into the lungs often tell us about the patient's condition. Especially if we plot these over a long time, so we have a comparison from patients' past to see if something has changed. And we can determine respiratory capacities by combining respiratory volumes. These capacities tell us more information about the patient's respiratory status. For example, rather unsurprisingly, the respiratory volumes and capacities would be typically abnormal on patients with pulmonary disorders. And what I would like us to do next is to look at a sample graph that plots the volume of air and its direction over time. And this is an imaginary dataset, probably reflective more of a male, but anyway, it will let us to learn some key concepts. So the first value that we see here at the beginning and at the end of the graph is something known as tidal volume, or TV for short. It shows us the amount of air that moves in and out of the lungs in a normal breathing. And a typical value for it would be something around 500 milliliters. The next measure that I want us to talk about is known as IRV, short for the inspiratory reserve volume. And it is again in the name where we find an explanation for what it tells us about. So this is the amount of air that we breathe in with the extra effort, in addition to the typical tidal volume. And in an average male adult, it would be somewhere around 2,100 to 3,200 milliliters. So a fair bit of variation there. And this variation would tell us about the health of an individual and so on. And then we have the opposite of this, known as ERV, expiratory reserve volume. This shows us the amount of air that can be exhaled with an extra effort beyond the tidal volume. This is typically about 1,000 to 1,200 milliliters. The last one that I have to add is residual volume, or RV for short. Figuring it out allows us to work out the amount of air that always remains in the lungs. Some is needed to keep the alveoli open. So now we have here our respiratory volumes. And as I said earlier, the respiratory capacities are then worked out based on these, by combining these in various combinations. Let's have a look at that. I know that this slide looks like there is a huge amount of things going on, but do not worry. We will go through it step by step. So the big message to get out of this is that to work out lung capacities, we typically add 2 or more lung volumes. So capacities are a sum of specific volumes. And let's work through this. Let's start with the inspiratory capacity. This is often abbreviated as IC. So this is a measure of all the air that we can get in. So both the tidal volume and the IRV. Next one is FRC. This stands for functional residual capacity. This in turn is the sum of the residual volume. Remember, this was the air that does not leave the lungs, and the ERV, the maximal amount of air that we can blow out. Those make sense, don't they? Let's carry on. We will now look at the vital capacity, VC. This tells us the maximal amount of air that we can breathe both in and out. So it is the sum of tidal volume, the normal breathing, and the maximal in and out breathing, so IRV and ERV. This is as much as your lungs can possibly get air moving. The last one for us to have a look of is the concept of total lung capacity. This is also known as TLC, and no, not the band. We get the total lung capacity when we add all these elements together, so IRV plus TV plus ERV plus RV. So we include also the volume of air that does not leave the lungs. So there you have it. You are now an expert of lung volumes and capacities. There is another concept that relates to what we have discussed here, and that relates to the term dead space. Let's have a look at that. There are two kinds of dead space as it relates to the respiratory system. The first one is anatomical dead space. This does not really contribute to the gas exchange. Instead, it consists of the air that remains in the passageways. This is typically around 150 milliliters of the 500 milliliters of the tidal volume. The second one, alveolar dead space, refers to the space that is occupied by, for example, collapsed or obstructed alveoli. So alveoli that is non-functional. Now that we have these two concepts, let's combine them. The total dead space of the lungs refers to the sum of the anatomical and alveolar dead space. Next bigger physiological concept that I would like us to discuss relates to the gas exchange. And as you might remember, this can take place in two different sites. Remember this diagram? Great! So we have two phases of respiration where the gas exchange took place. Firstly, between the alveoli of the lungs, remember these were the tiny sacs at the end, and the capillaries surrounding them. So we want to pick up oxygen to the blood and give away carbon dioxide to the lungs so that they can be breathed away from the body. So this would be within the pulmonary circulation. And then, of course, at the level of tissues during systemic circulation. So we want the blood to give oxygen to the tissues in the body, and we want the blood to pick up the carbon dioxide away from these tissues. And the blood was the transport medium to enable this to happen. While we know that gases are exchanged at these two sites, I think that the real big question here is for us to understand that what really causes this exchange of gases to happen. And this all relates to the concept of partial pressures. And you might have seen this explained as a measures of milligrams of mercury. And to be completely honest with you, to fully understand the concept behind the partial pressures would take us some time to review, but what we will do instead is to acknowledge that there are a few important laws from chemistry and physics that hold the answer to this. And instead, we will just accept that there are partial pressures and move on to consider how they drive the gas exchange. And to do this, what I think that we will do is to use two diagrams that I have prepared to my face-to-face students as handouts. And I think that there is no reason why they would not be useful for you as well. So on this first diagram, what we are seeing is a capillary of a blood vessel passing by an alveoli of the lungs. And I have included partial pressure values for both oxygen and carbon dioxide in a number of spots of this process. And let's go through those. So what we see is that the blood that arrives to the lungs comes with a partial pressure of oxygen being 40 milligrams of mercury. And we also see that the partial pressure of oxygen in air around us, and therefore in our lungs, is 100 milligrams of mercury. And this is the time when we refer to the very basics that we learned in our BIO181 or BIO156. You remember that the diffusion always happens from high concentration to low concentration. So the same is true for high partial pressure to the low partial pressure. And what we see is that there is a greater partial pressure of oxygen in the lungs than in the blood. So oxygen will move here from the alveoli to the blood until the concentrations are equal. As a consequence, the blood leaving the lungs has an oxygen partial pressure of 100 milligrams of mercury. So oxygen has been taken to the blood. And now, let's note that the same is true for the carbon dioxide, but in a reverse manner. There is 45 milliliters of mercury of carbon dioxide in the blood, whereas there is only 40 milligrams of mercury of carbon dioxide in the air around us. So at the level of the lungs, carbon dioxide moves from the blood to the alveoli. Remember, from high to low. And this is until these are equal. So as a result, the blood leaving the lungs has carbon dioxide concentration of only 40 milligrams of mercury. Now, let's look at the same at the tissue level on systemic circulation. So the blood arriving from the lungs has oxygen concentration of 100 milligrams of mercury, while the oxygen concentration in tissues, or in this example intestinal fluid, is only 40 milligrams of mercury. So again, from high to low until equal. So oxygen moves from the blood to the tissues. And the reverse is true for the carbon dioxide. Concentration in a blood arriving from the pulmonary circulation is for carbon dioxide 40 milligrams of mercury, while it is in tissues 45 milligrams of mercury. Therefore, carbon dioxide moves from the tissue to the blood at the systemic circulation. I hope that this has helped to explain the directions of how gases move in these two sides of gas exchange. Next, what we should have a look of is the respiratory gas transport in blood. So our question will be, how are these gases transported in the blood? And let's have a look of transport of oxygen first. Majority of oxygen is transported bound to hemoglobin, as I'm sure that you remember. And remember that in each red blood cell there were 4 heme groups, and each of these could bind 1 oxygen. And then the remaining 2% of oxygen is transported dissolved in plasma. How about carbon dioxide then? Well, majority of carbon dioxide is transported from cells to lungs as bicarbonate. And this brings us to this carbonic acid equation. And I will discuss it in a little bit in more detail when we put all this together. But notice that carbon dioxide and water make a carbonic acid, which then can be made into bicarbonate, which is then released through respiration. Rest of the carbon dioxide is transported as carbaminohemoglobin and in plasma. So what I want us to do now is something that we probably should do even more often. I want us to take one step backwards and look at the bigger picture. How does this all fit into the entire body scale? And this ties in quite well to the future chapters too. So what we are doing here, we are looking at several different systems and how they are connected. And we do this by following the path of certain chemicals. And I think that we should start somewhere that is familiar to us and easy to remember. Let's start with cellular respiration. So as you remember, here we take sugars, in this example glucose, and oxygen. And at mitochondria, this gets converted into energy. And as a waste product, we are left with carbon dioxide and water. Now, this is where I said that let's look at how carbon dioxide is transported. Well, when you have carbon dioxide and water, they can be converted into carbonic acid. And this series of reactions is known as our carbonic acid equation. So carbonic acid, in turn, can be converted into bicarbonate and hydrogen. And you remember that I said that it is as bicarbonate that most of the carbon dioxide was transported in blood, and as you see here, this bicarbonate is then transported to the lungs and eliminated via respiration. Then we are left with the hydrogen, and it turns out that we eliminate it with urine. So see how nicely we are able to tie in several systems that we have looked at and will look at with this series of reactions. One could say, I guess, that this is all that your body does. So, there are a couple of more concepts that I want to mention before we wrap up this video on the physiology of the respiratory system. The first one of these is whether altitude has an effect on the respiratory system. You might have heard a variation of a saying that a gallon of water weighs more at the Rockies. That version is actually what I say. I have a small place at the Rockies at the high elevation, and at first when I go there I always feel that doing all physical activities is very laborsome. Why, you might ask? And of course the water does not weigh more there. There is another explanation. The explanation lies instead in the fact that the oxygen content at the higher altitude is lesser than at the sea level where most of us live. So, what the body does to acclimate to the low oxygen content is that it produces more red blood cells and hemoglobin. There are also changes in the metabolism. So this is the explanation why some may get altitude sickness. And it is also explanation for high altitude training camps where athletes may go. After they return to the sea level, they may have theoretically an advantage with improved oxygen delivery to the tissues in the body. And of course, we have some groups that have adapted to living in high altitudes. And there is also a hormone, EPO, that can stimulate the same effect. It has been sometimes misused by some athletes. I think we talked about it on our chapter of hormones. Another thing that I want to briefly address is where the breathing is controlled from. Well, the brain areas that we know to be associated are the reticular formations of medulla and pons. However, these pathways are a little more complex, involving many levels, chemoreceptors, and reflexes. And the more detailed level of knowledge is still being defined. I also want to mention just quickly, what is a normal respiratory rate of an adult? What do you think? Well, we are talking about 12 to 20 breaths per minute. Of course, depending on the amount of work being done. It can change up to 10 or 20 times faster during heavy exercise. How about newborns and cats? I'm only including cats because I like them. Well, they breathe faster, about 40 to 60 breaths per minute. So do not freak out if you see a newborn breathing what happens to appear a little faster than what you are used to in your own breathing. And cats are just fun. One clinical condition that I wanted to finish with is hyperventilation. This results when the depth and rate of breath increases so high that the body's need to remove carbon dioxide is exceeded. So in other words, we are getting rid of too much carbon dioxide. Well, let's look at it a little more. One common cause would be anxiety attacks. So as we noted earlier, the carbon dioxide levels drop now too low, and that causes the tingling, shaking, dizziness, and can even lead to fainting if this is not stopped. One older approach to treating this is to make the patient to breathe into a paper bag, as it captures the carbon dioxide, and this way the patient will breathe some of it back. This would then rectify the situation, at least to some extent. And with that, we are going to wrap up this video on respiratory physiology. I know that it has been a lot that we have covered. Thanks for sticking around with me.